everybody.
Hi. All right. Hello and welcome, everyone. We really appreciate your time and attention today. We're here to talk about Cannabinoid Hyperemesis Syndrome, which quite frankly is a strange and traumatic syndrome. But before we get into the nitty-gritty of the data that we have to share with you, we want to talk about just a few housekeeping rules or housekeeping issues. First and foremost, we want you guys to ask questions. We have a Q&A section at the bottom of the ribbon on your screen. So as we go along, feel free to put your questions in that section of the Zoom screen, and then we'll get to them at the end. Also, everybody's audio has been disabled, and then we'll take those questions at the end. We'll have a full hour. This presentation is for everyone's individual educational use. You will receive a recording of this tomorrow, sometime in the afternoon, and we ask that you not share the link. In the future, the link will be available for purchase in the library on our Credo Science website. So let's get to it. We've got a poll that you will see here in the chat. So if you have a moment to answer that, we certainly would appreciate that. Our speaker today is Dr. Ethan Russo, and he certainly is somebody that is well known and probably doesn't need much of an introduction. Right. But we are going to put his bio in the chat so you can learn about his credentials. But one of the things that I personally appreciate most about Ethan is that, he left private practice after being in practice for over 20 years to go into clinical science and research, largely because he wanted to be able to help more people. And he certainly committed his career to the science and helping as many people as possible. And that's really what we have endeavored to do here with the work on CHS. And so, it's really our goal to be able to spread knowledge and awareness about this condition so that we can help more people. And so with that, the always generous, thoughtful, and incredibly competent Dr. Ethan Russo.
Thank you. Well, welcome everyone. I'm going to share my screen and we'll get going with the, whoops, there we go. Great. I hope everyone can see. I'm just going to adjust a couple of things. And so our topic today is Cannabinoid Hyperemesis Syndrome. This initial study that we're going to be describing in detail was done with the team that you see on the right. My email is at the bottom. I'm quite happy to hear from anyone with questions subsequent to the meeting. And there's the website for Credo Science, and we'll be dropping other links into the chat along the way. So let's get started. And okay, certain controls are working and certain are not. So conflict of interest, just so that everyone understands, we are going to be discussing a technology where we have a patent pending, and there is a commercial test available through our partner Endocanna Health as the exclusive licensee of the technology that we'll be describing. So let's define terms. What is cannabinoid hyperemesis syndrome? So this was a real enigma. The index case went clear back to 1996, but wasn't reported until 2004 in Australia, where there was a case series of several patients that developed this weird constellation of symptoms associated with chronic use of THC, generally in high doses. So what was described then in 2004 is pretty much a spot-on description of what we see today. So affected patients go through severe cycles of nausea, vomiting, and abdominal pain. And then there's a pathognomonic behavior that occurs with it, where the person finds relief temporarily in either hot showers or baths, and often for hours and hours a day. Seemingly, abstinence from cannabis and THC exposure is the only definitive treatment, but as we'll see, cutaneous application of capsaicin ointment might temporarily abort an attack, and there are variable responses to standard antiemetics. More facts. The previous largest case series was at the Mayo Clinic in 2012 with 98 patients. And then there was a pretty comprehensive review of available studies, 105 studies as of 2018. But the best description of the pathophysiology of this disorder came from Marika DeVuono and her team at Guelph in Canada. And she described phases, a prodrome of nausea and vomiting, anxiety and sweating, that leads to another phase of hyperemesis associated with the abdominal pain and the compulsive hot bathing behavior, and then a period of recovery following abstinence. And we'll be going into these in more detail. Another interesting fact is there have been two estimates in the literature of what people have had to spend to get a positive diagnosis of CHS. And these have ranged from $26,000 a patient to $95,000 a patient, and that was in 2012 money. And so it's probably worse now. Unfortunately, there have been at least 2 deaths directly attributed to this syndrome. People involved had such electrolyte disturbances that it led to their demise. So this is a serious disorder. Standard antiemetics are poorly effective. So your ondansetron, granisetron, etc., don't do a very good job. Seemingly, haloperidol is better, and as mentioned before, the topical capsaicin. From Marika's article in 2020, there are some very interesting relationships. The pathophysiology includes biphasic nausea and vomiting response to THC. It's well known that low doses of THC are antiemetic, but in anyone, even without a CHS tendency, at too high a dose, it becomes proemetic. Seemingly, there could be a downregulation of the CB1 receptor, and definitely activation of thalamic pituitary axis with stress responses very prominently. She had hypothesized a genetic predisposition, but as of 2020, this was not as yet defined. Quite rightly, she pointed out that common misconceptions about pesticides and neem exposure as causative here have been totally unsubstantiated, and their symptoms do not match those of CHS. There was a study done in New York City in 2018 trying to guess the prevalence of CHS, but they had a very strange methodology. They surveyed patients at the ER at Bellevue that were there for other reasons. They asked them about their cannabis usage and whether hot showers or baths, not baths, reduce vomiting. From this, they went through some transmogrification of the data. They used this strange definition of CHS, not CHD. They ultimately thought that 33% of heavy cannabis users might have CHS. If we extrapolate that to the US population, it's close to 3 million Americans could have the diagnosis. I think that that's a wild exaggeration, but let's just say it were 1/10 of that, it would still be 350,000 people and very noteworthy. The project that we began was based on the theory I came up with that Cannabinoid Hyperemesis Syndrome might be related to mutations, particularly single nucleotide polymorphisms or SNPs that affected genes encoding the CB1 receptor. That gene is called CNR1, or particularly the TRPV1 receptor where capsaicin works. Seemed to be an interesting relationship there. Or perhaps it could have to do with THC metabolic enzymes if there were a problem there. So we decided to undertake genomic testing in partnership with Endocanna Health. We developed an extensive screening questionnaire to try to nail down the diagnosis. This went through the standard IRB process and was approved, and the study was open for essentially a year with 585 total respondents. Now, 205 patients fulfilled strict diagnostic criteria of CHS, including having a diagnosis by a physician and ongoing symptoms. We did not want to include anyone that might have been diagnosed as having CHS, but say was abstaining now and may have been misdiagnosed. Of the 205 patients meeting the diagnostic criteria, 99 agreed to genomic testing and were sent test kits. Unfortunately, only 28 returned them, and I would point out at this juncture that we had a great deal of online interference from the CHS community. People questioned our motives. We were accused of profiteering or not knowing what we were doing or ignoring pesticides. And there was a lot of consternation about this. We also identified 54 controls. These were people who had very heavy cannabis usage, as we'll see, but didn't have CHS symptoms. So we had 12 of those that had genomic testing. So in total, this is by far the largest CHS study to date, and it was the first to examine genomics systematically. Now, I am not going to go through this in detail. This one is over my head. You could ask me questions about it, and I would draw a blank because this is the methodology of the genotyping. So not being a molecular biologist, I will just say that this went through peer review and was properly done. So be it. Just summarizing the survey results, and we'll go into more detail. Again, there were 205 strictly diagnosed and confirmed CHS patients. They were high frequency users of cannabis, 91% daily or greater, using cannabis flower concentrates, median of 4 grams a day of THC predominant material. So this obviously qualifies as heavy usage. Interestingly, 15.6 carried diagnoses of cannabis dependency or addiction at some point, and a whopping 57% had experienced withdrawal symptoms. Vast majority, 88%, improved after they stopped cannabis, but almost all suffered recurrence rapidly after resumption, and this is what is commonly reported. Now, among the controls, use patterns were quite similar, as we'll see. 100% were people that continued to use cannabis within a year, 70% daily or greater, again, mostly by smoking high THC material. Now, in contrast to the CHS patients, less than 4% had ever been labeled as having addiction or dependency to cannabis, and 76% had never had withdrawal symptoms. Only 11% had ever been told that they needed to stop for health reasons. So going into some detail, this is the schematic of the CHS patients, again, 205. You see from the use on the right that we're clustering around 4 grams a day, mostly smoked. Again, 100% of the controls were also cannabis smokers, and again, with a very high intake, but not displaying symptoms of CHS. And we asked about the composition of the material. As it turns out, 89% was THC predominant. The rest were probably type 2s with some amount of CBD along with the THC. And it was really not so different for the controls, 80% also THC predominant. How people characterize their use, either recreational or adult use, 56%, 38% identified be in both camps. And it was 44% of controls characterized their use as recreational. In terms of why people would use medically, as is commonly the case, chronic pain and sleep disturbance are preeminent. Some people were actually treating nausea or trying to treat nausea. In the controls, it wasn't that different. Chronic pain, sleep disturbance, and a lot of migraine, indicating possible efficacy there. Very few of them were trying to treat nausea in distinction to the CHS patients. Again, had the person ever been diagnosed or treated for dependency or addiction, 44 people responded to this one, 22% said yes, but only 3.7% of controls. And again, whether people have been told to stop, the vast majority, 92% of the CHS patients have been told this, but apparently the message did not stick in this instance, but was only 11.1% for the controls. And withdrawal symptoms, again, 75% for CHS patients, but 24% for controls. So 76% did not ever have withdrawal symptoms. In terms of what kind of withdrawal symptoms, typical anxiety, panic, depression, insomnia, nightmares or vivid dreams. So nothing unusual there. Asking about nausea and vomiting. It was an exclusion for controls to have had this problem, so that figure was 0. But in terms of the frequency for the CHS patients, 41% once a month, 30% once a year, but then we get up into 14% weekly and 16% more often than weekly. And you can understand how this would be very disruptive of one's lifestyle. And 87% have been hospitalized for nausea. This is from 93 patients who answered there. Abdominal pain, 100% of the 205 patients who answered this, on 0% for controls. And how often does the abdominal pain occur in patients? Again, 27% more than weekly. So again, quite serious. And hospitalizations for abdominal pain, 79%. Whether the symptoms that we've talked about stopped after cannabis cessation, 90% said yes, 10% noted continuation, but we'd have to dig in more to see what might be going on there. Was there improvement with hot baths or showers? 100% among the patients, 0% for controls. And whether people had been diagnosed, this was, again, something that we required for inclusion in the CHS cohort. So that was 100%, and it was 0% for controls. And how long did it take to get a diagnosis? So for 60%, it was a year or more, 21% several months, only 7% got a diagnosis right away. So this is a continued problem. And what kind of treatment had been tried? Antiemetics, obviously, most frequently attempted. A few people got opioids. People obviously tried cannabis to treat the symptoms. Not as many as I would hope had gotten capsaicin, but again, almost everyone had used the hot baths and showers. And duration of episodes, for 69%, several days, but for 15%, it was an ongoing problem. And whether people improved after cessation, again, 90% improved once they stopped cannabis usage. However, 79% after a period of abstinence resumed its usage. This is a common thread when we talk to caregivers. And how long was it before symptoms returned? 69% after more than a week. And for a lot of people, it was less than that and probably commensurate with their exposure to THC. And almost all the people, again, had increased their intake and possibly developed tolerance again as symptoms resumed. And we asked people what they thought CHS was about. 38% didn't know and wanted to find out. Some thought it was due to TRPV1 receptor problems. 2% thought neem and 6% pesticide contamination. And we would just consider these totally disproven. 30% thought a problem with the endocannabinoid system. And 8% thought it was psychosomatic, which again, we really reject. So just looking at the demographics of the CHS versus the controls, control subjects tended to be a little bit older. Interestingly, we had a female predominance in both groups, and I think this is more attributable to a willingness to go through a prolonged questionnaire than anything else. Our suspicion is there's a male predominance of CHS, just as there is in heavy cannabis usage. But we do not have a big enough sample to say that for sure. Now, what I really wanted to highlight here is the difference between the control subjects with 0% in the gastrointestinal symptomatology as compared to the patients with CHS. And this is a table of our genomic results, which we're going to go into in detail. Now, the ones that are bolded are the ones in which we saw a statistically significant difference, p-value under 0.05, between the results for the CHS patients and the controls, along with the odds ratios. And then you have the percentages displaying the gene variant. And as you can see in the top 5 there, they're quite different one to another. Then there were a few genes where things were close, but not quite there. And I would just point out this one in particular, CYP2C19, which is one of the cytochrome P450 enzymes that breaks down THC, just as CYP2C9 is, although that one is the preeminent. So our first hypothesis was that there was a problem in these folks with the CB1 receptor gene, CNR1. Previously, SNPs had been noted along with cannabis usage, but we didn't see that here. Now, interestingly, there is a disorder that's often confused with CHS called cyclic vomiting syndrome, which is a form fruste of migraine, usually appearing in childhood, where there's nausea and vomiting unassociated with headache, often until the child is older. Interestingly, a lot of those people do get benefit from treating with cannabis, but it creates a lot of confusion in the diagnosis. One way to tell the difference is those folks do have a SNP on the CNR1 gene, whereas the CHS patients do not. So a point of differentiation. The first gene where we did see a relationship was in COMT, Catechol-o-methyl transferase gene. So a mutation called RS4646316 was observed in the intron, the introductory area of the gene, in 57.1% of the CHS patients, but only 10% of controls. The p-value was quite significant, 0.012. Well, what does it do? COMT catabolizes catecholamines, especially dopamine. So if there's a loss of function, it leads to dopamine excess. That is often characterized by compulsive behavior, substance abuse, gambling, and sex addiction. And a good example of that is some Parkinsonian drugs induce this kind of behavior when people are treated with them. This particular mutation has also been linked to depression, rumination, and heavy alcohol intake, particularly at a young age in women. Similarly, it can be associated with impulsivity, disinhibition, attention deficit, obsessive compulsive disorder, anxiety, and psychosis. People that have this have also been noted to have more likely cognitive impairment by cannabis. So this seemed to make a lot of sense. The second place where we saw a statistically significant difference was one of our hypotheses, that there was an issue with the TRPV1 gene, encoding the TRPV1 receptor where capsaicin works. So this mutation was in the downstream part of the gene and affected 71.5% of the patients and only 30% of the controls, again, highly statistically significant. TRPV1 has been linked to anxiety and pain responses in the brain. It mediates long-term depression in the hippocampus, and it controls glutamate in the solitary tract nucleus, which affects gut motility and secretion, which certainly makes sense in context. Now, previously, no TRPV1 polymorphisms were observed in relation to cannabis dependency, but presumably they didn't have a lot of CHS patients in their cohort. This specific mutation was not previously listed in the National Library of Medicine database, but it does suggest a linkage of CHS to mood and gut disturbances, as well as the hot water exposure behavior and the efficacy of capsaicin in trying to treat it. Again, CYP2C9, drug metabolizing enzyme, and this is the main metabolizing enzyme for THC. Here, a homozygous mutation was seen in the CHS patients in 46.4% and only 10% of controls. And that still attained statistical significance. This also works on arachidonic acid, and it, again, is the main metabolizing enzyme for THC and its primary metabolite, 11-hydroxy-THC, which is also psychoactive. When this enzyme is hypoactive, it could lead to THC accumulation, which could kick people into this biphasic dose response towards pro-emetic effects of THC. Or there's even the possibility that there's production of abnormal metabolites, which could be toxic. As we were publishing this, there was one patient that was observed to have a dual mutation in this gene, who also had cannabis dependency and a personality disorder. So not very surprising. The next mutation we saw was in the DRD2 gene that codes for the D2 dopamine receptor, which is the target of antipsychotic drugs. So we saw a mutation there in 61% of CHH patients and only 20% of controls, again, statistically significant. Drugs that are stimulants of DRD2 are pro-emetic and affect gut motility. So that's an interesting relationship. Mutations on this gene have been associated with depression and anxiety, which are quite common in CHS patients. Other mutations been associated with nicotine addiction, Tourette syndrome, and chronic pain. And the combination of this mutation with that on COMT that metabolizes dopamine may help explain many of the associated psychiatric sequelae and symptoms of CHS. The next statistically significant difference was in the ABCA1. That's the ATP-binding cassette transporter. Here again, there was a homozygous mutation that we saw in 68% of the CHS patients and only 20% of controls. This gene affects cholesterol and phospholipid homeostasis and can be associated with the accumulation of an abnormal protein, ApoE and A-beta deposition in Alzheimer's disease, so associated with dementia. Unfortunately, if someone's homozygous for this mutation, it could imply an increased dementia risk later in life. Other associations have been noted to coronary artery disease and type 2 diabetes. A related gene, ABCB1, was associated with cannabis dependency. So there may be a relationship there. So overall, we had 5 mutations with plausible etiologic roles in the phenomenology of CHS. We believe that the test battery that's been developed may be a valid screening diagnostic for susceptibility to cannabinoid hyperemesis syndrome. It would be our hope that a test costing $200 could obviate the need for repetitive interventions, sometimes invasive, that have skyrocketed the cost of hospitalizations for these folks. And I'll just read this. Cannabinoid hyperemesis syndrome can contemporaneously be conceived of not as a functional or psychophysiological gastrointestinal disorder, but rather as a manifestation of gene-environment interaction in a rare genetic disease, unmasked by a toxic reaction to excessive THC exposure. And we have some resources. We'll make these links available to you. The article itself is available at the first link on the left. Also, all the questionnaire data is there. Subsequently, I've got a LTE to another journal we call Myth Busting Cannabinoid Hyperemesis Syndrome. That's just a short thing that may be helpful. And we have a website we'd like to direct you to, what-is-chs.com, with a lot of facts for patients and physicians, and also a link to the newly released DNA susceptibility test for CHS. And with that, I will stop screen share and hope that we've left sufficient time for questions.
Thank you, Ethan. That was excellent, as usual. We have a question, and before we get to it, I'd like to invite anybody else who has a question to put it in the Q&A chat, and we'll take them as those questions come. So we have been asked, did an increase in CBD have an impact on reducing the nausea?
Maybe. So this is a great question. I'm glad to be able to address. As you may know, CBD shares with THC the ability to be an antiemetic. Unfortunately, we can't answer the question fully because very few CBD preparations are totally devoid of concomitant THC. Even the so-called isolates, when they've been tested, often have what we'll call in this instance THC contamination. We had previously asked some patients to try and use CBD preparations to see if they got benefit from them without triggering symptoms, but unfortunately the results have been mixed. Some people felt that temporarily they did better, but this was not uniformly the case at all. And as so often is the case, people often feel that they can just start with a little THC, especially if it's organic, and that they won't have a problem, but inevitably they succumb to the recrudescence of symptoms. So right now, it's possible that CBD would be part of a solution to this, but we can't recommend that. It just hasn't been uniformly helpful.
Excellent. So our next question is about CBN. Do we know if CBN can also contribute to hyperemesis?
Yeah, great question. I think it's highly likely it would. Basically, what we know is that CBN is also a CB1 agonist, perhaps 25% of the potency of THC. As such, it very likely would trigger CHS if it's present in a sufficient amount. What also supports this is there was an excellently documented case of someone who had used cannabis and had CHS, stopped the cannabis because of their job in urine testing, but instead went to high potency CB1 agonists like K2 and Spice and redeveloped CHS symptoms over a period of 6 months in which it was documented that there were no THC metabolites in his urine. So it's clear that any CB1 agonist can similarly trigger CHS, and that's the reason it's should be called Cannabinoid Hyperemesis Syndrome rather than Cannabis Hyperemesis Syndrome, because in this instance, you might not be using cannabis and still would have the phenomenology of the disorder.
Excellent, thank you. So capsaicin cream may also be useful for pain. Is there any connection?
Well, it'd be hard to say. What we know about capsaicin use, say for neuropathic pain, like when people have painful feet associated with neuropathy, it takes a long time to work. You have to deplete the substance P in the neurons over a period of time. And that's in contrast to the application of capsaicin ointment in CHS, where the relief often comes on in about 45 minutes and lasts for some hours. So yeah, I could have a role, but, and I would just point out here, and this is interesting, I think, when people take capsaicin orally, say with hot chilies, it is very poorly absorbed. The proof of that is sometimes it hurts on the way out as it does on the way in. Actually, the bioavailability of capsaicin, what gets into the blood, is greater when it's applied cutaneously than when it's applied orally. So it's not a situation where people should think that you give a CHS patient a hot chili like a habanero to take, that's going to help them. It will not.
Has CHS been noticed with high doses of navalone?
There's no reason to think it would not be. I can't say that I've heard of that, but it likely would place a person at risk. I think it's a good bet. Navalone is a semi-synthetic THC analog, and it's 10 times the potency of THC. So I have no reason to think that it would not be a trigger to CHS.
Thank you. What other isolated cannabinoids and acids may be safe for these patients?
To be fair, we've got to say it remains to be seen. Let's use the example of THCA, tetrahydrocannabinolic acid. Now, normally THCA has shown antiemetic effects as well, but part of the problem is it's not very stable. So let's say we had a tincture of THCA and had been sitting around too long, it's going to have THC in it. And so it would be risky. If we had a stabilized THCA, it's possible it would be helpful, but these are just among the many things that we'd like to be able to investigate and answer better. But this has been a really tough nut to crack. First, in understanding it, and we hope that we've advanced that a little bit. To diagnose it, again, we hope we've helped. Where we haven't helped yet is advancing diagnostics, and that is the challenge for the future.
That's an excellent segue into the next question, which is, now that the possible genetic basis for CHS has been identified, what are you intending to do next?
Well, first thing is we want people to use this. As they do, we hope that we can better understand. And for instance, we identified some genes that look like they might be involved. Maybe we find out when we have 1,000 patients that some of these are significant as well. Additionally, we hope that this will allow progression into possibility of better treatments. And we have some theories about how this could be done, trying to optimize the endocannabinoid function, but without CB1 agonists. And there are ways of doing this that'll probably be the subject of a future webinar So I don't want to give too much away, but we have ideas. Yes.
All right, so we have two similar questions, so I'm going to kind of lump them together. Can you talk about where you may have seen CHS sufferers who have abstained from cannabis return to it after some amount of healing?
This is the most common pattern. I've heard of people that have gone a year or two of abstinence and think maybe they're out of the proverbial woods and can try again, but it usually ends very badly. Again, this is a susceptibility that people seem to have, and it doesn't necessarily go away even with abstinence, unfortunately. So we wish that that were different. We also have heard, and there are people that seem to develop triggers that don't necessarily involve cannabis. I've heard a few times now that people get triggered by black pepper. Black pepper does have caryophyllene in it. That's a CB2 agonist. However, there may be some conditioned responses. We can't rule out that some cross-reactivity comes about because of similar taste, smells, or other environmental influences that trigger someone. So, we are complex organisms, and there could be a lot of possible explanations for this kind of phenomenon.
Do you think it's possible for somebody who has their genes tested and then they show up having the genes that make them susceptible for CHS could alter their cannabis usage in a way that would not ultimately trigger CHS?
Yeah, possible, but risky. We hear a lot about people that have kept their usage down to a very low level, and only upon escalation or the development of tolerance get the symptoms resume. But it's always risky. And we know from personal experience where people have gotten into trouble when they've been away from home, really bad situations, going into an era where no one knows them and they don't have their medical records, and it can be really difficult.
So we have a couple of people who are watching today who have CHS and through the chat are sharing some different experiences. And so can you address why one patient has such a different experience than another, especially when it comes to their recovery, and that some can't be around, they can't even be around cannabis use, and others feel like if they are just using a small amount, they might be able to not trigger symptoms of CHS. What's contributing to the variation in experience?
Yeah, well, being exposed to people smoking cannabis, that could be a conditioned response. A reminder of what they've been through, that people can make themselves sick by thinking of things that disturb them, unfortunately. So that's possible. And again, where the line is, how much can someone use before they get it? That does absolutely vary from one individual to another. There also is a situation of somebody who smokes cannabis for the first time and gets sick. What's that about? Does it mean that they're susceptible to CHS? Well, it may, but it also may be that, it was too big a bong hit, or their first exposure to cannabis was in a high potency vape. And that's too much for anybody that hasn't developed tolerance. I never recommend that somebody use a vape pen as their first exposure to cannabis if they're going to go in that direction. So again, we don't know yet, but it may be that the difference between these people and their reactions has to do with their combination of mutations or their underlying endocannabinoid tone, which is something that we invoke but can't measure very easily. at this time. It would be great if and when we have functional scans that allow us to assess the state of someone's endocannabinoid system. But right now, the best way to do it is with cerebrospinal fluid exam, doing a spinal tap and measuring it directly, but that's not something you can get through an ethics committee very easily.
A little harsh.
Yeah.
So in doing this work with you, one of the things that really struck me as I participated in many of the CHS support groups online is that so many of the people who have CHS find it incredibly challenging to be able to quit the thing that is making them sick. Can you address why?
Yeah, it's really unfortunate. As we've seen, people that have this really like cannabis for the most part. And so on the one hand, it's something they miss and would like to be able to use. On the other hand, unfortunately, and again, I'm not casting aspersions here, for at least the people that have these mutations in the dopamine system, they're susceptible to having addictions. And it's not just to cannabis, it could be to tobacco or alcohol. This is a situation where I'd really recommend that they think of alternative treatment. This can be counseling. It certainly can include lifestyle factors. Another thing we've noticed, especially Nisha and her travels and discussions, is that unfortunately many patients with CHS don't have very healthy diets. It's really possible that diets that encourage, involve prebiotics and probiotics might increase the gain of the endocannabinoid system and offer some protection. I can almost guarantee that people that do this are going to feel better in general and maybe not feel that they have the need for cannabis. Meditation would be another really good idea. And aerobic exercise, particularly low impact. These kind of things are well known to increase endocannabinoid tone and maybe a partial solution at least.
For the gastroenterologist and other physicians who are attending today, what do you recommend that they do when a patient presents with these symptoms?
Well, obviously, the first thing is diagnosis. Hopefully, they've got a good enough rapport that they can ask the person about the cannabis usage and get a straight answer. Unfortunately, this is still an illegal substance most places, and it's not always a good time. Gastroenterologists need to be aware that patients are going to be quite resistant, oftentimes, to the idea that cannabis is creating the problem and isn't the solution to the problem. On a first visit, I think that diagnostics really may be necessary, but I really would wonder if we can't place the genomic testing at an earlier stage to try and replace some of the more invasive tests and save money. But obviously, again, there are controversies about genomic testing. People may be aware of the rare instances in which information has been used by law enforcement to arrest their cousin, this kind of thing. I would point out that Endocanna Health has totally anonymized the data and it's not shared with law enforcement. So we can at least allay any concerns about confidentiality of the genetic test results, which would be available to the patient, but not to people who lack the code to access.
Thank you. So are there cases of CHS that persist even after total abstinence for a significant period of time? And if so, what's causing this?
Well, again, some people report that. The more common scenario is for it to abate after a period of abstinence, but there are people with persistent symptoms. in that instance, I think the best medical advice is to ascertain if anything else is going on. Could it be that this is a person with cyclic vomiting syndrome that was misdiagnosed? So is there an association with migraine or migraine and history of this cyclic vomiting since childhood? And they may need further investigation. What we want to avoid is people spending months and months and $96,000 before they're diagnosed, and we hope we can help there.
Excellent. So we've been asked, are there any forms of cannabis ingestion safer than others in terms of CHS, such as vaping versus stomach ingestion?
Sure. Not that we're aware of. I'm afraid that any THC exposure places a person at risk. I will say this, however, vaping is going to give the most rapid rises in THC bioavailability, or smoking for that matter. It also is going to produce a quicker offset as well. Drugs that act fast and go away fast are more prone to producing reinforcement, meaning the person's more likely to get into continued dosing, which is going to lead to the development of tolerance. And it's just that scenario that places a person at greater risk for the development of CHS if they have the susceptibility. Now, again, let me emphasize, not everyone who smokes a lot of cannabis gets this. One of the things I think that we've established is that certain people are at risk, not everyone is at risk. Now, one question that might come up is, say that you had a sibling that had CHS and you were a teenager thinking of starting cannabis for whatever reason. Might it make sense to get the screening done? Quite possibly, but that's obviously an individual decision by the patient, their family, and their doctor. But we, certainly we'd like to see this used liberally, and we can learn more along with everyone else.
All right, so guys, we have about 8 minutes left. So now's the time to get your final questions into the Q&A. So while you're thinking about that, just wanted to point out that we have shared some links in the chat for you, just in case people have an immediate curiosity about how to order the kit or to look at what is chs.com. Or our journal article. We'll also include those in the email that we're going to be sending to you tomorrow. And feel free to share them widely. They are there to help educate people and spread the word about this syndrome. So, Ethan, how many genes of the 5 that were identified in the research have to occur in an individual for them to be susceptible to CHS? Is it just one or multiple?
We don't know yet, but that's one of the first questions that we'd like to be able to address when we have bigger numbers of folks. So yeah, as they say, watch this space.
All right, so what is being done from the distribution and awareness aspect to inform the public and dispensaries?
Oof, that's a tough one. One hopes when you publish an open source article, it'll get picked up by the media and get lots of attention. That hasn't happened so far. So we need some help on the evangelistic front. If people do this testing and find it helpful, either to themselves or from a clinical standpoint, hopefully they'd spread the word. Yeah, we'd like to see more traction for this. We really think that this is fundamental to an understanding of this problem. And this is a genuine public health issue at this point, with a number of people involved, the suffering that they go through. Again, 2 patients at least have died from this. it has major impact on people and their ability to function and their enjoyment of life. So we need more insight, more help on getting the word out.
Thank you. So someone writes, this was partially answered before, but does a single individual's threshold needed to develop CHS get lower after each time they have the symptoms, or does the threshold for CHS to occur in a person remain stable?
I think it's pretty unpredictable. We've had people that have gone through abstinence, returned to it, took a while to develop. Then the next time they quit and resume, it happens right away. I don't think that it's eminently predictable. So it is like the proverbial high wire act. You never know when you're going to fall.
All right, great. Well, thank you so much. There are no additional questions at this time, so we're going to wrap up the webinar. Just want to thank all of you who have been attending and watching for your time and your attention, and certainly we'll make a plea to all of you to please help us spread the word about CHS, and together I think we can help a lot of people. So thank you all for being here.
Thanks for joining. Cheers.